a pleasure being with all of you today, and we'll review some things I think are pretty important. This metabolism, I looked that up, and the definition is the chemical processes that occur within a living organism in order to maintain life. So that's pretty significant, pretty important there. So if we look at this picture, we ask ourselves, which of these links is most important? And you could say, it's easy to tell that if any one of these links is broken, you're going to have some bad results from that. And that's the way it is with the thyroid system. Of course, we need TSH. Of course, we need T4 production. But the T4 has to get converted to T3. The T3 has to get to the receptors. And the receptors have to generate a certain amount of metabolism. So T3 is critical to the regulation of the metabolism. And thereby it affects virtually every bodily function. The exciting thing about that is that like we were talking about yesterday, is it could be a lot more patients could be benefiting from this than we previously thought. So the thyroid, the glandular system presents T4 to the cells, but the cells are, and the tissues of the bodies where actually the metabolism and the regulation of the metabolism takes place to a very large degree. Whoa. Okay. So so there's a lot more regulation going on in the periphery than was previously thought, which is exciting because that means a lot more people could benefit from treatment than we've been thinking of before. If you look at this, you've seen this diagram a couple of times so far, but this is 5' deiodinase, and they refer to that as D2 or deiodinase 2, type 2 in the literature. But that is what converts, it plucks off this iodine atom and converts T4 to T3. But notice the same enzyme converts reverse T3 to T2. So the D2 has the effect of making more T3 and making less or destroying reverse T3. But there's another enzyme called D3, type 3 deiodinase, that does the exact opposite. Notice that this enzyme makes more reverse T3 and makes less or destroys some of the T3. So depending on whether you have D2, there's some, and the regulation of the system makes it such that when D2 is being expressed in the cells, then you have greater metabolism, and when it's expressing D3, you have less metabolism. So this is an example of this. This is D2 expressing cells, or in other words, when the metabolism is turned on. So you have T4 coming in, and it's converted by D2 to T3, and that goes into the nuclear receptor. Notice that the T3 from the plasma also goes into the cytoplasm and goes into the nucleus as well. So this nuclear T3 pool is dependent on both of those. And when you have D3 expressing cells, the T4 comes in, and the D3 converts it to reverse T3, and that T3 that would otherwise be there is gone. It's not there. And T3, same thing. T3 comes in, the plasma T3, and not very much of it gets to the nucleus because some of that is converted, some of that's destroyed as well. And the interesting thing about this is this local control of thyroid hormone action. It's tissue specific and time specific, which is interesting, which means that some of your tissues in your body might be turned on. The D2, it's D2 expressing, while at the same time other parts of your body could be turned off. And that's irrespective of what the TSH level or the T4 or reverse T3 or anything like that. And not only that, but what tissue might be on this morning, might be D2 expressing this morning, later on in the afternoon might not be D2 expressing. So it's time specific and it's tissue specific. So, when you look at that, it's like, wow, almost all of the regulation isn't in the blood. It's not in the blood test. It's not the T4. It's not the TSH. It's in the cells. And let's review. We're going to review some of the signals that can affect that to eliminate that a little bit more. So what the T3 and T4 influence gene expression in virtually every vertebrate tissue. These signals result in a thyroid hormone interaction with the thyroid receptors, and that affects the transcriptional complex inside the nucleus and affects the transcription of genes, which is going to determine what proteins are in the tissues and what functions are going to be happening accordingly. And like I said, this happens even when the blood tests are normal. So let's look at some examples. So under cold stress, person goes under some cold, they might get some norepinephrine released. And this goes to the beta adrenergic receptors, stimulates cyclic AMP, and causes the deubiquination of the D2 enzyme from these mediators, and that turns on the enzyme D2, and then the more T4 is converted to T3. And with an uncoupling process, you have more heat production in the brown adipose tissue especially. When they do that, of course, they increase T3 production. So bile acids are steroid acids and that look like cholesterol. They emulsify fats in the digestive tract. And half the cholesterol the body makes on its own is converted into bile acids. And 95% of the bile acids secreted in the gut are reabsorbed through this enteropathic circulation, taken back to the liver for reuse. And they stimulate the metabolism and energy expenditure in brown adipose tissue, helping prevent obesity and insulin resistance. Isn't that interesting? So a lot of people think, obviously if you eat too much fat, you could gain a lot of weight. But it may be that if you eat too little fat, you could slow down your metabolism and struggle that way too. So it may be important to have at least a little bit of good fats in your body to at least get this bile acid effect to help yourself along. Sonic hedgehog is a protein that is important in development of the fingers and the fetus and the brain, and this deactivates actually D2 through this. It ubiquinates the D2 and deactivates it, and that decreases T3, and that's important in the developing fetus. Dr. Cunningham mentioned yesterday how in the fetus the T3 levels, the conversion of T4 to T3 can be decreased. So, and sometimes in the development of the fetus, it's important for that to occur, and when you're, and other times it's detrimental when we're adults. So in the growth hormone affects regulation of thyroid function in general, and it affects the peripheral T4 metabolism, or the conversion of T4 to T3 in particular. And in turn, T3 can increase growth hormone levels. So this is another example of how there's certain mediators or signals or factors that can turn on the metabolism so that it stays on. See, if the T3, let's say you give a person T3, and that increases their growth hormone levels. And then in turn, the growth hormone levels improves T4 to T3 conversion, and bang, it's another thing that helps your metabolism turn on and stay on. Serotonin is only 1/3. Can't see this slide, but only 1/3 of the patients achieve remission on antidepressants. And on the other hand, T3 can correct up to 50% of treatment-resistant depression. So if you think about that, it's even possible that if, like a lot of doctors, they'll see a patient that's depressed, and you can't really, and their first thought is antidepressants. And I'll give this person antidepressants. Well, this is kind of suggestive that your first thought might be T3. And the reason why is because 50% of 2/3 is 1/3. So 1/3 is going to get better with antidepressants, 1/3 is going to get better with T3. And not only that, but these 1/3 that got better with T3 are ones that failed on antidepressants. And how many of these people that did okay on antidepressants would also do well on T3? So you could also, they might have done well on T3 instead. So it would be interesting to see a study that most of the research on T3 and depression is the augmentation of antidepressants with T3, but I'd really like to see some studies that compare antidepressants head-to-head with T3 in treating depression. So I like the statement that's made in one of these studies here. It says, so the conclusion is optimal thyroid function beyond simply being within the normal values may be necessary for optimal health. And so it's kind of a subtle statement. It's kind of a subtle statement, but it means that maybe you can ignore the blood tests, and the person, and treat the patient and not the blood tests. T3 can often correct bipolar symptoms. There's one of these studies shows that T3, some of these people with bipolar symptoms, they had a bunch of patients and they failed on an average of 14 different medicines. They were given 14 different medicines and failed. And then a lot of times those people got better with T3. So it's kind of... The research is surprisingly scanty on body temperature. And I just think that's really surprising. It's such an important physiological parameter, and there just isn't really a lot of research on it. But this particular, I like this. Look at this, 1942. It was important in 1942, and this is, of course, Dr. Barnes, Broda Barnes, who was a pioneer in the importance of low body temperature and thyroid. He did a study with a hypothyroid rat that had a rabbit that had a low body temperature that went up with thyroid hormone, and the basal metabolic rate increased as the temperature went up. And in this case, they showed in 1998 that the thyroid physiology and body temperature go together. When the physiology is better, the temperature is better. And in 1974, one study showed that they concluded that this mouse was hypothyroid because the low body temperature of the mouse normalized with thyroid hormone. And in this case, they increased body temperature in mice in 1 day with T3. So they were able to demonstrate that, getting the temperature up in 1 day. Low body temperature and low T3 and high reverse T3 predicts increased mortality and death rate in the elderly in hospitals and nursing homes. So this, I think this is really interesting. If you look right now, if you do a Google search on hypothyroidism, and you'll go to prominent medical sites like PubMed or something, and you'll see that they don't really, maybe I should say WebMD, something like that. They won't always list low body temperature as a symptom of hypothyroidism, but this PubMed Health website does list low body temperature as a symptom of severe hypothyroidism or myxedema. And one of the main symptoms that people have when they have these low body temperatures and they have normal blood tests is they have fluid retention. They have puffiness and skin. They have edema. They might not have mucopolysaccharides or in their skin, but we tend to discount it. I don't know. You can see a patient that is just horrible looking, and the doctor says, "Oh, you must have thyroid." So they do the test, and the test, the doctor is sure it's going to be a horrible test because the patient looks so bad. And then the test comes back normal, and it's like, whew, you're fine. That's great. But I mean, it's just like, but we're kind of trained ourselves to do that. But I mean, it's just really interesting to think that these people, even though their blood tests are normal, could have very, 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 very severe hypothyroid or hypometabolic state. They might be in severe hypometabolic state, even though their blood tests are normal. In other words, they could, in a sense, be myxedematous. You know, even though their blood tests are normal, and we're just like, oh, we just discount it like it's nothing. And the thing that kind of confirms that is when you give them T3 and they spring back to life. So I just trying to emphasize the fact that, you know, if a person has normal blood tests, they might still be in a very severe situation. So maybe low body temperatures can be a sign of very low thyroid hormone expression. Might be, I mean, like doctors tend to say, oh, well, you've got a low body temperature, so don't worry about that. But, you know, it's just like, oh, you've got a low body temperature. That could be like a really severe sign of very severe, you know, hypometabolic problems here. You know, we better pay attention to that. And this is kind of an example of that. We know that when the temperature is super high, it's a medical emergency, and if it's super low, it's a medical emergency. And if it's a little bit high, you have a fever and you get off of work. But this, if it's a little bit low, you know, it could be just a little bit, it could be just as low as this is high, and it could be a very, very bad problem. And we just discount it, but we shouldn't. Reverse T3 can in turn inhibit D2 and set up a vicious cycle. So you've seen this, that stress, fasting, illness, cortisol, these things are known to impair the conversion of T4 to T3, turn down the system. You know that reverse T3, that this same enzyme converts reverse T3 to T2, so that there can be competitive inhibition here. And I always, you know, before a lot of this research came out, I was in my mind, I mean, it acts like once this gets too high, it kind of creates a vicious cycle and gets stuck. So I always imagined in my mind that it was due to competitive inhibition. And it does competitively inhibit, but it means like, sorry. So yeah, it can go down and stay down. Fasting has been shown to decrease the conversion, and that results in a sustained depression of the metabolic rate even after refeeding. And these people can, after massive weight loss, they can continue to have with a slow metabolism. So the question is, how can you have this switch being flipped and staying this way for 20 years, even though the half-life of reverse T3 is a few hours and the half-life of D2 is less than an hour? It's just like, you know, what causes that to get over there that way and get stuck that way? Can it happen? One idea is, have you ever felt refreshed after a 5-minute nap, you know, or a 10-minute nap, and you feel like a whole lot better? Well, what happens if you don't get that nap? Do you still feel that kind of refreshment? And what if you don't ever get any sleep again? You know, you're going to die. So so what happened in those 5 minutes? And what would have happened if you hadn't taken a nap? And it just shows that dynamic systems can sometimes get stuck. So even though things are happening 20 minutes here and an hour there, they can still get out of balance, and they can stay out of balance as long as they're go that way. Picture this little blade of grass here, and so then you've got this nice push mower here, and you could say, can I inhibit this lawnmower with this blade of grass? It's here today, it's gone tomorrow, it's just one little blade of grass, not going to make any difference. And you'd say, probably not. You know, it's only lasts 20 minutes or 40 minutes, it's not going to make a big deal. But if you have a lot of those blades of grass, and they're tall and they're thick, and you're pushing that mower too fast, and it's being overwhelmed by all that grass, and it's getting bogged down and clogged down, and it's going to slow down, and it's going to stall, and it's going to stop. That can happen. And if you push that mower through that grass too fast for too long, it'll stay sluggish for 20 years. If you push it through tough grass for 20 years, it's going to stay sluggish for 20 years. And that's the kind of thing we're looking at with this. So what can be done? One thing that can be done is you can give T3, and that changes everything. Because when you do that, the TSH goes down, T4 goes down, and when the T4 goes down, the reverse T3 disappears, T2 goes down, and when the reverse T3 disappears, the D2 comes back up. The D2 is not being suppressed, and okay, it's not 20 minutes anymore, it's 40 minutes. And so then you wean off the T3, and the T4 to T3 conversion is back where it should be. And so you're not overwhelmed, you're refreshed, you're cleaned out, you've had your slate cleaned, and then hopefully you'll do well after that, and perpetually. So giving the T3 can increase the heat production. So this has the potential of bringing about a long-lasting reversal of hypometabolic symptoms in patients who are euthyroid. These are a couple of recent posts on Facebook that this person went 10 years and then had to get treated again 4 years or 5 years later. This person's used T3 twice over the last 20 years. So 10 years, probably 10 years later. So in a way, I'm going to show you a study here in a second that says that one of the things it says you have to give hyperthyroid amounts of T3 in order to increase the body temperature. But it's not hyperthyroidism in the sense that Graves' disease, when people have Graves' disease, they're making up to 900 micrograms of T3 a day. And the kind of doses we're talking about on the high end are 90 twice a day, which is 180. So it's nowhere near Graves' levels. And the people that are taking the T3, their temperatures, you never give it when they're you never keep increasing if they're having palpitations or jitteriness or anything like that. And their temperatures are not too high. So it's not, if their temperatures ever go too high, you don't keep increasing it. But it's not thyrotoxic levels. So this is the same kind of paradigm that we use in oral contraceptives to treat irregular menstrual cycles. It's diagnosed clinically, a therapeutic trial to see if the symptoms resolve. You wean off the T3 to see if the symptoms remain improved. It's really not that complicated. This is the therapeutic trial. It's the most common basis for medical treatment in the U.S. Antidepressants just became the most widely prescribed medicine in the country, and they're given based on a therapeutic trial because depression doesn't show up on blood tests. And the rationale that they use for T3 and hypothyroidism is hypothyroidism can cause depression, and so maybe if you have depression, it'll get better with T3, even if the blood tests are normal. And that's why they give thyroid. That's why that's the rationale that they give for that. Then you can consider, and so in a similar way, if hypothyroidism can cause all these symptoms of hypometabolism and a low body temperature, then people with hypometabolism and a low body temperature might respond really well to T3 medicine. This is a study in NIH. They gave patients T3, 4.5 pounds they lost on T3 as compared to T4. Cholesterol, LDL went down. No change in the heart rate, blood pressure, or exercise tolerance. This is the one I mentioned about you have to give, when they say hyperthyroid levels, I assume they mean sometimes you have to give enough T3 to lower the TSH in order to get the body temperature to normal. And that's totally expected. And this is interesting. The ability of T3 to increase the body temperature is enhanced with exercise. That's a good pearl. That's a good thing to remember. So the patients, when they're on T3, and you're having trouble getting their body temperatures up with T3, you definitely want to emphasize the importance of exercise. So so this just goes back to the idea that it's really easy when you look at those kinds of mechanisms and things and what the research is showing. It's really easy to get the feeling now that really the glands are there to supply T4 to the cells, and the tissues are there to regulate the metabolism. And that, like I said, that means that a lot of people may more benefit from thyroid hormone, especially from T3, than was once thought. I wanted to point your attention to also some videos, some tutorial videos on how to use T3. And if you go to wilsonsyndrome.com, there's a video link. There's a tab that says video, and under that tab there's tutorial, T3 tutorials for physicians. And there's 8 videos. They take 30 minutes to sit through, and I think you'll find them pretty clear, pretty helpful. And I think, seems like I was going to mention something else. Let's see. Yeah, I wanted to take a quick mention to talk about something called compensation time. When you give somebody T3 medicine, as soon as you give them the medicine, their body tends to make less TSH, less T4, less T3. So you might give them 7.5 micrograms, temperature doesn't change. You might give them 15 twice a day, 22.5, and the temperature goes up. And you say, oh, great, the temperature's up. But it wouldn't be surprising if even after the temperature goes up that it should come back down again. And that can come back down usually in about 2 or 3 days. So that's a compensation time of 2 or 3 days. And some people compensate in 6 days. And so if a person compensates in 2 or 3 days and then you increase it to the next dose, their temperature might go back up. And then 2 or 3 days later, it might come back down again. Then you increase it, it goes back up, and then it comes back down again. So that person is a 2 or 3 day compensator. And that's to be expected. And they'll tend to keep doing that until their temperature doesn't come back down. And then you could call that their temperature has been captured. But if you... But some people are 6-day compensators, and some people are 1-day compensators. So the take-home lesson, the thing I wanted to mention to you, is some people can compensate so quickly that they can actually overcompensate. So if you give somebody 7.5 micrograms twice a day today, and then tomorrow they come back and they say, hey, or they call you and say, hey, my temperature is lower now than when I started the medicine. Isn't this supposed to get my temperature to come up? That's somebody that's your first clue that this person might have compensated so quickly that they actually overcompensated. So that's a really fast compensator. And those patients, it's counterintuitive. And those patients are going to tend to, the faster you compensate, the more unsteady your T3 level is, and the more chance you have of having side effects like shakiness and jitteriness and palpitations and things like that. 1/10 of the patients are fast compensators, but they're going to account for 50% of the side effects or more of the problems that you face. And so you might think, oh, this person's, temperature's lower than it was yesterday, and they're having side effects, and so we're going to need to be more careful in this patient. We're going to need to go up more slowly. And that would make sense, but that's wrong. It's counterintuitive, but actually it's safer. We're not going up slower, but going up faster, because the idea, it's kind of like pushing a baby, like a kid on a swing. If you want to keep them in a tight range, you push them up, and before they swing back down, you push them up, and before they swing down, you push them up, and you keep them in this tight range. But if you don't, if you push them up, and then you let them swing all the way through baseline, and then you push them again, and swing all the way through baseline, and you push them again, the amplitude just gets bigger and bigger and bigger. So rather than keeping them in a really tight spot, you're just amplifying their T3 levels to where they're just very unsteady. And so you might increase some of those people 7.5 every 12 hours. So, and one point is, last point I'll make about that before we go to questions is, on the other hand, a slow compensator tolerates rapid increases very easily. Like if, it's a slow compensator, if you increase them 7.5 micrograms, every day, they tolerate that fine. So anyway, a rapid compensator a slow compensator tolerates rapid increases a lot better than a fast compensator tolerates slow ones. And for that reason, the tendency is, or a good idea, suggestion, is to go up quickly on the T3. Because the T4 is in the system and it's kind of stabilizing influence. So in general, when you use T3, and cycling is important, but when you use T3, you want to go up smoothly and quickly, and then you kind of wean gradually off and see how well they hold on their own again. And if you need to do another cycle, deliver it smoothly, quickly, and then wean them gradually off like that. And that's the thing that tends to help people get better. And I think we have time for questions.
Yeah, so if you can go to that microphone for questions.
Okay.
Good morning. Couple questions for you. What's the general rough interval that you would use to titrate somebody up and bring them back down, just in general?
In general, 1 month, you could do a cycle in 1 month. You could do a cycle in 2 to 3 months. You could leave a patient on there 6 months or a year, because what happens sometimes is a person goes up on the T3 and their temperature's not perfect, but it's good. And you say, let's say their temperature's normal, but they're not 100% better. And they're probably not 100% better because they're on 90 micrograms twice a day. They're on a lot of medicine. And their temperature's normal, but it's not steady enough. And so you say, well, you're like 70% better than you used to be, and we want you to be better. You're not going to get better until we wean you off and start you up again to hopefully get you normal on less medicine. And so you'll say, so let's wean off now. And their knuckles tighten and turn white around the bottle. And then they say, this is the first time in 20 years I haven't had a migraine. And if it's all the same to you, or they might say, for the first time I'm losing weight. And, they're not having side effects, they're not having complaints. If they're losing weight, that's a happy accident. Not accident, but not everybody loses weight. But some people, when they get their temperature up, I've seen people lose 100 pounds. And I've had one lady lost 34 pounds in a month. But even so, 34 pounds in a month. And anyway, so when somebody's rolling along like that, then you can leave them on there that way for months, because I think it protects their metabolism from the adverse effects of dieting that might otherwise slow their metabolism. So if they're not having complaints, you can leave them on that for a long time. But normally it's like, 4 to 6 or 8 weeks in a cycle.
One other question, and I wonder if you might comment on a phenomenon that I've discovered over the past few years using hair mineral analysis, which is that patients who are classically hypothyroid and have low high TSH and low thyroid hormones will demonstrate hypercalcemia and hypermagnesemia on their hair mineral analysis. And we've also often understood that a lot of these patients will come in, they'll have the symptoms of hypothyroidism, their serum levels will be fine, but they'll still show that real high calcium and the high magnesium on their hair mineral analysis, indicating that intracellularly they've got a low thyroid effect.
That's really
so we've seen that for a number of years, and some of the research and the information you're giving explains why there's control at the intracellular level. I find that kind of interesting.
Yeah. Thank you very much. It is interesting. It really throws things around when you think it's just like, oh, guess what? The blood tests don't give you any indication really about what the metabolism is doing. Oh, okay.
I have a few questions. When you first see somebody, I'm trying to sort out in my mind who this is most applicable for, which patients. So I see a lot of patients, of course, that are hypothyroid and autoimmune hypothyroid. So a lot of the patients that I'm seeing, well, I see so many different things, but let's say somebody's coming in and they're already on Synthroid. They've been on Synthroid for a very long time, and they've got some symptoms that warrant you having them take their body temperature, and their body temperature is low. So what are you doing with the Synthroid before you're doing this?
Good question. I would almost always, in a case like that, I would consider a therapeutic trial of T3. Mainly, you want to use T3 in patients if they have low body temperatures, if they have one or more symptoms that they want to try to get rid of, and you can treat it. As far as what you do with the Synthroid, as far as transitioning them, there's more information on the wilsonsyndrome.com site. There's down at the bottom, there's a free e-manual, and it's like the doctor's manual, and chapter 12 explains what you do in a hypothyroid patient with T4. But other than that, basically you can wean the patient off the T4 quickly over a period of 2 or 3 days, and then you can leave them off for 10 days and then start ramping them up on T3. And you would, but during that 10-day period, you could give them a little, you can increase the T3 as needed to prevent a worsening of symptoms. And then after that, you could, so letting the T4 and the reverse T3 go out of their system before you're doing the T3. That's one way of doing it, but an easier way of doing it, easier way to explain it to patients is you could just start weaning down the T4 after over 2 or 3 days, and just start increasing the T3 at the same time. So you don't have to really wait 10 days.
And you're continuing down on the T4 as they're coming up on the T3.
Yes.
And then if they get unstable when they start getting up to top doses, then do you just halt? Do you just stop the decrease of the T4 to stabilize them?
No, the T4 is going to be out of their system long before. Well, you're going to be off the T4 in just 2 or 3 days. Okay. So like if someone comes in on 0.125 milligrams of T4, you could have them cut that in half one day and go off it the next day, and or go down over 2 or 3 days, and then they're completely off, because the half-life of T4 is 7.5 days. So even if you stop it abruptly, it's still going to be in their system. Yeah. And so then you could start adding the T3 on top of that. But yeah, once the T4 is completely out of their system, and they are on a bunch of T3, and they're getting any shakiness or jitteriness or things like that, you can give a T4 test dose to stabilize that. You can give them a touch, and you wouldn't necessarily need to give it every day. You might give it a very small dose, like half of a 0.025 milligram tablet. You give half every 2 or 3 days as needed, just PRN.
Thank you. Just one other question. Do you see a difference in treatment outcome with people that have a history of, like, let's say, Graves going to Hashimoto's versus somebody that has no autoimmune picture with their hypothyroidism?
Not so much in terms of responding. They respond indistinguishably from treatment. But a person that has Hashimoto's, or that has some autoimmune illness or some thyroid damage, they're going to be more likely to relapse. But as far as responding to the treatment, they respond indistinguishably.
Okay. And they don't have to go back to their T4 oftentimes?
There's some people that have had hypothyroidism, and everybody thinks hypothyroidism lasts for a lifetime. Yeah. But that's not always true. Like, I've had bona fide blood test documented hypothyroidism from a patient 20 years ago, and then she got better with the T3, and then after cycling on T3, we weaned her off, and her TSH came back to normal. Her thyroid function came back up to normal after 20 years, and I've seen that after 8 years. So sometimes people, they had hypothyroidism, primary hypothyroidism 8 years ago, and they went on T3, and now they don't take any thyroid medicine. But I don't think that's so much a factor of the T3 fixed their hypothyroidism so much as their thyroid gland recovered over that period of time. The T3 fixed their peripheral conversion impairment, got them back functioning again. But their T4, their thyroid gland started working, but the T3 got their metabolism working. So.
Okay, sorry to cut the questions off. We're out of time for this lecture. Dr. Wilson will be speaking again at 11 o'clock, so in about an hour, so you could ask questions then. So thanks so much, Dr. Wilson, for a very informative lecture. We really appreciate it.